Good evening, Taz.
Hi, Philip. Nice to speak
Hi.
to you.
Thank you very much for agreeing to talk to us a little bit about diabetes and Ramadan.
No problem.
We often
Delighted.
get, yeah, thanks. We often get a lot of questions from patients about Ramadan and should I fast? Should I not fast? What's your advice, doctor? And I know this year is like last year is going to be a long fast for 16 to 18 hours. So I'd be really grateful for your advice on how we can help patients come to the decision about whether fasting is for them or maybe fasting is not for them.
Sure.
Where do we start with this?
So I suppose, Philip, the first thing to say is that this year is going to be very different Ramadan to normal years for lots of reasons. COVID is prevalent in the community, and we're socially distancing, so we're not going to be doing the same things that we normally do. So normally during Ramadan, I'd be going to the mosque in the evening and this sort of thing. I'd be breaking my fast with my family and maybe going to people's houses and breaking my fast and so on. So this Ramadan is going to feel very different to people, and people are going to be a little bit sort of at sea with it, really. So it's going to be a little bit different, but in terms of the physical sort of health, actually it's exactly the same as last year. It's the advice to patients with diabetes is going to be exactly the same as it has been over the last few years, is that actually if you have diabetes and you have significant health complications, perhaps related or even unrelated to your diabetes, that actually you may want to consider whether you need to fast or not. So we can explore that a bit more, but I think the main message to say is, ideally, and it's perhaps a little bit late now, but ideally patients with diabetes should be consulting their doctors, and that's, I know, quite challenging at the moment, but even over a conversation online or over the phone, consulting with your doctors or your nurses about whether I should fast for Ramadan is important, and you can still do that now. It's still possible to do that now. But I think the main thing is to think about whether it adversely affects your health. And your conversation with Professor Yaqub, the kidney specialist, a short while ago, touched upon that as well, is that we know that Islamic scholars are very clear about this, that actually if fasting is going to adversely affect your health, then you should not fast. And actually you should be strongly discouraged from fasting, because fasting is not about damaging your health or damaging yourself. It's about a spiritual rejuvenation, and it's an important month for all of us as Muslims. But you don't actually have to fast to get that spiritual rejuvenation.
Yes.
You really mustn't be hurting yourself or damaging yourself in any way. So I suppose the message, the primary message would be to people with diabetes: try and consult with your doctor or nurse and have a discussion about whether you should or shouldn't fast. That would be the first thing I would say.
Yeah. And how can we unpick those patients who, obviously everyone would like to fast in Ramadan, an important one of the 5 pillars, but how do we unpick those patients who we should advise that maybe this is bad for you and you shouldn't on those grounds fast? Do you have a sort of high risk, moderate risk, low risk?
So I mean, there are a lot of guidelines out there. I mean, actually quite a useful guideline that health professionals might want to look up online is the Diabetes and Ramadan Alliance. Okay, so this was if you Google DAR Ramadan guidelines, you'll get them up, and they actually are a very nice guideline. They're fairly wordy, and there's a lot of pages to them, but they actually give you a nice way of actually stratifying risk in people with diabetes. And not everyone with diabetes is at high risk. So it actually will look at very high, and moderate or low risk. And it will tell you within that document what sort of people might be at very high risk of fasting. And the sort of patients that we are concerned about are, of course, the patients with diabetes that is poorly controlled, and particularly if they've got other comorbidities, and particularly, I suspect, I'm sure Magdi must have touched on this with you, is renal comorbidities, particularly getting dehydrated during Ramadan, but also cardiovascular comorbidities as well. So the people that are very high risk are those sort of patients. Also, you look at their treatment as well. People on insulin, much more high risk than people on oral hypoglycemics alone. There is some good sort of evidence-based advice out there that is useful to look up. But to some extent, it's a matter of common sense. It's a patient who is perhaps elderly, with significant renal disease, on insulin or sulfonylurea, and has, is at risk of hypoglycemia. And those are the sort of patients that you probably should be saying, well, look, this is a fast that you don't need to do. You're at high risk, particularly of hypoglycemia and dehydration. And perhaps you might want to forsake your fasting this year.
Yes. There are other things you can do instead of fasting. Am I right in saying that?
Absolutely. So lots of people do a number of things. So you can pay the fidya, which is the sort of payment per day of days that you haven't fasted, and that's perfectly valid and a good way to make up. Some people actually make up their fasts later in the year. So I've got many patients who actually decide they're not going to fast during the month of Ramadan because it's just too long. They're going to fast in the winter and actually choose November, December, and fast where it's 8 or 9 hours. It's much easier, much safer, and they get something really good out of it. So, I mean, there are lots of other ways of fulfilling your obligation as a Muslim if you are advised not to fast.
Yes.
The only other thing, Philip, that I would say, to health professionals, is maybe the first question you might want to ask your patient is, what did you do last year? Okay, so actually the first thing you say, doctor, I want to fast. What should I do? Well, actually, how did you get on last year? And remember, last year was actually even longer than this year.
Yes.
So, if they successfully fasted last year, if there hasn't been much of a change in their health status right now, then actually, maybe they could get away with it and give it a go. So I think that's a really important question to kick off your consultation with is, well, how did you get on last year? What did you do?
Yes, good. And delving more a little bit into the high risk and the very high risk patients, we talked a little bit about chronic kidney disease, patients who maybe had an EGFR. I think Professor Yaqub was saying around 45 or less should actively be encouraged not to fast because of the extra damage that can happen to the kidneys. Obviously, patients who are on dialysis, either peritoneal or hemodialysis, and also patients with kidney transplants were the big factors that he highlighted. Where would you pitch? I had a look at the guidelines on levels of HbA1c. Would you be thinking about a certain level of HbA1c in terms of control?
The guidelines do say sustained poor glycemic control, and probably the preceding 12 months. Yeah. And certainly, if I've got a patient with me with an HbA1c much above 75, which is about 9%, yes, I would say that they're at pretty high risk. Now, clearly, an HbA1c of 75 suggests that their glucose perhaps is, high most of the time. But nevertheless, actually, some people with higher HbA1cs are also more prone to hypoglycemia as well. Yes. So someone certainly on insulin with an HbA1c sustained at above 75, I would be a little bit careful about. But actually, equally, someone with an HbA1c less than 53 with on insulin, I would also be a little bit mindful about because of their risk of hypoglycemia. Yes. Particularly on
so that J-shaped curve with problems. Yes, and we sometimes get asked by pregnant women with diabetes about fasting. Yeah. Is that also a category where we should be advising not to fast in?
Yeah, I mean, look. Pregnancy is very much an area that there's strong advice, both Islamic and medical advice, to say that you shouldn't fast during Ramadan.
Okay.
I mean, not only is there a risk to the mother, but also a risk to the baby, lack of nutrition, and so on. So it can be quite risky to fast during during pregnancy. We strongly discourage it. In the antenatal clinic and the diabetes antenatal clinic, we reiterate that advice over and over, and hopefully, and most women actually heed that advice and do their fast later. So we would strongly advise women during pregnancy, diabetic or not, to not fast during pregnancy.
Okay, that's very clear. Thanks. So let's get on to how we advise those patients who we think are of low or moderate risk. How can we help them make their fast bearable, and what do we tell them to watch out for if they are fasting and on medication? The guidance, I think, is moderately clear around how you change the tablets, and obviously there are a couple of categories of tablet that we have to be a little bit more careful with than others.
So, I mean, you're absolutely right. The guidance is clear that things like metformin, gliptins, liraglutide, GLP-1s, these sort of things probably don't need a huge amount of adjustment. One thing I'll just mention to you about SGLT2, so the
Yes.
empagliflozin, canagliflozin, dapagliflozin type drugs, many of our patients are taking these now. Again, a little bit late now, but I would generally not be starting these drugs within sort of 2 to 4 weeks of Ramadan, really, because of the sort of dehydration effect that's going to occur initially when you start these drugs. So people get a bit dehydrated. Certainly during Ramadan, I would not advise you starting these drugs in someone who's actively fasting. Because they will get more dehydrated. So I would avoid gliflozins. I certainly wouldn't stop gliflozins during fasting.
Okay.
So if someone is stable on them and doing well with them, just leave them on it. They should be fine. But I wouldn't be starting them within 1 month or during Ramadan. So gliflozins, I would be a little bit careful of. And just one more thing about gliflozins is that actually if you have a patient who sort of phones you up or you do a sort of video talk with them, and they say they're feeling unwell with abdominal pain, with nausea, with some vomiting, just be a little bit mindful about the euglycemia induced ketosis that we can see with gliflozins. And during this COVID crisis, we've seen a lot of patients coming in with ketosis related to COVID. And there appears to be a slightly higher risk with gliflozins as well with these sort of patients. So just be mindful that if you do have patients who come with those sort of symptoms, please check their urine ketones. And if they've got heavy ketonuria, you probably should be sending them into hospital if they are on gliflozins. So those sort of drugs are generally well tolerated in Ramadan, don't need to make too many adjustments to them. But the main drugs you need to make adjustments to are the sulfonylureas and insulin. So sulfonylureas, repaglinide, insulin, those would be the sort of drugs that we need to think about adjusting.
Okay, so the classic patient on metformin and gliclazide, for example, taking gliclazide twice a day, metformin twice a day, how would you adjust their doses?
So generally what we would suggest is that you probably need at the start of the fast to reduce your sulfonylurea. So if they're on 160 milligrams twice daily, generally what I would do is half the dose. So take 80 milligrams with their start of fast, and take the 160 milligrams at the end of the fast when they break their fast. So that's generally what I would do. It depends sort of on the level of control. If they're very tightly controlled, I might even suggest taking no sulfonylurea first thing before the fast. If they've got an HbA1c less than sort of 53, I might say, well, actually don't take any of the gliclazide at the start of the fast, and just continue your nighttime gliclazide at the break of the fast. So that would be the sulfonylurea. And we actually do very similar advice with insulin as well. So with someone on twice daily insulin, for example, if they're on twice daily Novamix 30 or Humulin M3, which are the usual insulins that we're tending to use in type 2 diabetes at the moment, I might say exactly the same. Take half the dose with your start of your fast, and the full dose with the end of your fast, and you should be fine. You again actually might want to, because many of these patients have fasted the year before, a few years before, find out what they did last year and how did they get on. Some of them have managed it perfectly well last year by taking half the dose or adjusting the dose the previous years. Ask them what they did last year, and that generally will work quite well for them this year as well, providing there's been no change in their health status.
Okay, good. And the metformin, you can keep the metformin as it is?
Yeah, I have no concerns with metformin. Again, you want to be a little bit careful with patients with CKD, but actually the evidence suggests that actually people with stable CKD don't have any increased risk of deterioration of CKD over Ramadan. So I don't have a great problem with continuing metformin. Once the GFRs go to below 45, though, I think that there is a bit of a risk. So yeah, we should be discouraging people with GFRs less than 45. If they're absolutely insistent on fasting, you might want to think about reducing the metformin in that sort of cohort of patients. If they're absolutely insistent that they want to fast, then you might want to think about reducing. And as you know, once we get to a GFR of 40, we probably should be reducing metformin anyway to 500 BD rather than 1 gram BD.
Really useful, thanks. So you mentioned insulin, and of course we've got many type 2 diabetic patients on insulin, usually glargine or similar. Would you advise that just at the time that you break fast on a once daily basis? Is that?
Yeah. So again, a lot of these patients might be taking once daily long-acting insulin, such as glargine, Lantus type insulins, or a humanin I type insulin, which is slightly shorter, sort of intermediate acting, and they might be taking that before they go to bed once a day, generally outside of Ramadan. Probably the best time to take that might be at the break of fast, actually. So the break of fast around about sort of 8 p.m. It's going to be about 8:30 this year. So around about that time, take the insulin, and that will probably tide them over during the rest of the day as well.
Fine, great. Well, that's very clear. Occasionally, we have patients who are on twice daily insulins. Would you convert that to a once daily preparation?
I generally don't do that, Philip. The problem with that is that actually then you're not quite sure what dose to take and so on. If you do that, you should probably be doing it, at least a few weeks before you start Ramadan and getting them to do, some practice fasts and that sort of thing. I generally don't convert to once daily, but if someone is very tightly controlled, maybe getting some hypos, you might want to consider that during Ramadan if they phone you up and say, I'm having some problems.
Okay. Now, I guess the other topic we should discuss is type 1 diabetics. Do you have any strong feelings? I mean, diabetes in our lifetimes has become from a completely secondary care specialty to lots in primary care. Type 1 diabetes, though, still I think we feel is still the provenance of colleagues in the hospital, and how do we manage those requests that come in to us in primary care from type 1 diabetes?
Yeah, so again, within that DAR guideline, type 1 diabetes is deemed high risk, and is deemed as a person with type 1 diabetes can be advised not to fast. Now, I think just a really important point about this advice not to fast is that if you feel a person is at high risk of having adverse events during Ramadan, whether you're Muslim or not, it doesn't matter that that you're giving the advice. If your advice is that the person is high risk, you should say so. Actually, so what I'm trying to convey is that many patients will heed that advice and be relieved by it. Okay, so they actually want you to say that they are free from that obligation. Okay, they will heed that advice, and if they get that from a medical source, they will heed that. So if you have a person with type 1 diabetes, you are perfectly justified in saying the guidelines that we have available to us tell us that people with type 1 diabetes are exempt from fasting. Now, if they say to you, well, look, I've fasted all my life, I want to fast again, then you need to work with them. And what we generally do, again, is just tailor the advice according to what they're doing. Most of our type 1s will be in touch with us about it. So I've certainly had a few conversations with a few type 1s over the phone about fasting and what to do with their insulin. Clearly they'll miss out the sort of lunchtime insulin. They won't have a lunchtime insulin, but they'll always take their basal insulin. They might take a little bit less for their first insulin at the start of the fast, but generally, actually, they manage reasonably well. Just a couple of points is that actually this is for type 1 and type 2, is that we strongly advise that you don't fast if your glucose at the beginning of the fast is less than 5. Okay, so 5 or less, you shouldn't start your fast. And at any time during the fast, if your glucose goes above 17, then you should stop the fast. So that's general advice actually for any person with type 1 diabetes and type 2 diabetes on insulin. Essentially, if you're hypo at the start of the fast, low at the start of the fast, you're going to go lower. And if you're high at the start of the fast or at any time during the fast, you are at risk of developing hypoglycemic emergencies. So the advice generally for type 1 or type 2 is look at those sort of levels and break your fast if your glucose is outside of those range.
And am I right in saying that if you tested during your fast and it was lower than 5, then that's another indication to break?
Yeah, absolutely. So there's another indication to stop your fast. Now, again, some people are very reluctant to that. They've got an hour to go to break their fast. They're reluctant to do that. So it sort of depends. But if that's happening at midday, where your glucose is, at 5 at midday, you really are not going to be able to manage. You ought to be breaking your fast at that stage. And so people generally are fairly sensible about that and understand that advice. They understand that the risk of hypoglycemia is very significant once you're starting to go below 5.
That's really useful advice. Thank you. And that brings us on to testing, actually. We spent most of the last 10 years being encouraged not to give people glucometers. I always think that during Ramadan, there might be an indication if people feel that they want to fast during Ramadan, and that could be something that helps them stay safe.
I mean, I would commend that, Philip, if it is feasible to give people a means of testing their blood glucose, particularly if they're on sulfonylureas, I think. So, I mean, hopefully all of your patients on insulin should be testing anyway. But actually there has been a big vogue to try and avoid giving glucose tests, glucose strips for people on oral hypoglycemics. I think the sulfonylurea issue is quite significant. Patients do go hypo on sulfonylureas, and they should be testing if they're on them. So I think if you could offer some flexibility, particularly over Ramadan, for testing during Ramadan, I think that would be very helpful for our patients.
Yes, good. Well, that's I think that's covered virtually all the bases. So if I was to summarize then, just to check that I've got the message, in general, fasting is an incredibly important part of life, and incredibly, Ramadan is one of the 5 pillars that should be respected. That there are some diabetic patients who we really should be advising not to fast, and those include patients on insulin, those very high risk, so patients with HbA1cs that would be in excess of 75, and certainly if it was in 3 figures, that would be considered to be high risk. Pregnant women, and especially pregnant women with diabetes, and those with comorbidities, EGFRs maybe less than 45, and cardiovascular disease that was concomitant with the diabetes. But otherwise, we should be guiding patients who wish to fast with moderate or low risk diabetes to adjust their medicines in a specific way. And that would be to halve the sulfonylurea dose or omit it completely in the morning or at the beginning of the fast, and to keep with the standard dose of metformin in the evening and the morning, and the standard dose of glycoside in the evening. And many of the newer anti or hypoglycemic drugs are to be taken as normal.
Absolutely, that's perfect, Phil. A good summary. Just two other things I just wanted to mention to you. Number one is that actually I haven't touched on diet, so we haven't talked about dietary advice, and it's so important during Ramadan. So diet, unfortunately, there is a propensity to have high calorie, high carbohydrate sort of foods at the end of the fast. So actually what ends up happening is that you get a spike in glucose that goes very high at the period of not fasting. So that can be really problematic. So breaking the fast with sort of low GI foods is a really good thing to do. And actually there's some really good information for patients on Diabetes UK website about the sort of things that you can break your fast with. There's lots and lots of really good information about that. So thinking about diet and really reinforcing that to our patients about how they break the fast and how they start the fast is really important.
Yeah.
And so
we've come up with a very useful calendar for Ramadan, which lists all the foods that maybe you might consider rather than samosas or umbrella sweets or whatever. So there's some healthy options that should be nutritious as well as pleasant.
And the only other thing to mention is that, although perhaps less relevant this year, but things like screening tests, eye screening, and appointments for your regular checks and so on, people should turn up for those or cancel them. Please don't just not attend, because it's very important. Now, clearly, I know the NHS is in a different place right now, but previous years we've had really big problems with people not turning up or not cancelling their appointments, non-attendance at various appointments in primary care, in their retinal screening, their foot screening, and so on. That's very important, just as a thing to just mention to patients that you really should go to your appointments or cancel them if you can't attend.
Great. Well, that's wonderful. Thank you very much for that, Tahseen. That's a really comprehensive guide through diabetes and Ramadan, and I'm sure will be of great use to clinicians in Tower Hamlets and beyond. Thank you very much for sharing this evening with us, and thanks for all the work that you're doing in the hospital in this dreadful time, and best of luck to the villa.